Hello everyone, my name is Miriam Konomou and my project will be on Coxiella burnetii Q fever. The disease Q fever is caused by Coxiella burnetii, a gram-negative obligate intracellular bacterium. It is a zoonotic disease and it spreads through inhalation of aerosols and the consumption of infected animal products. Symptoms can be mild, flu-like, or they could be acute fever, malaise, headache, fatigue, atypical pneumonia, and even hepatitis. The disease is highly infectious, with less than 10 bacteria needed to cause the disease. The disease has two antigenic states, phase 1, which is the chronic state, and phase 2, which is the acute. They can be detected through immunofluorescence assay, and we test for IgG and IgM antibodies for each of phase 1 and phase 2 stages of the disease. The disadvantages of these diagnostic tools is that antibodies to Q fever can appear 10 to 15 days after the onset of acute disease. Convalescent samples are required to be able to make the proper diagnosis for Q fever, and the recommendation is that the patient follow-up tests 3 consecutive serologic tests in the first year after diagnosis to detect if the disease has progressed to chronic Q fever. This recommendation is difficult to follow up. The patient might not come back to get tested 3 times so that the diagnostician can make the proper diagnosis. I have chosen to discuss the study entitled Diagnostic Usefulness of Molecular Detection of Coxiella burnetii from blood of patients with suspected acute Q fever. The study took place between January 2016 and July 2018 in the Republic of Korea. It was performed at the 2,700-bed tertiary care teaching hospital in Seoul. Patients enrolled in the study were patients who were admitted to the hospital with suspected acute Q fever. Their symptoms had to be fever of unknown origin with one or more signs of rigors, headaches, hepatosplenomegaly, elevated liver enzymes, or pneumonia. The molecular methods used in this study were DNA extraction and a PCR assay. For the procedure, they collected 4 ml EDTA blood from the patients, centrifuged it at 134 G for 5 minutes. 200 microliters of plasma were used to extract the DNA. The DNA was extracted using the extraction kit QIA-AMP DNA mini kit. For the lysis, they used the buffer and proteinase K, left it in a 70 degrees Celsius water bath for 10 minutes, washed twice, and eluted the samples in 200 microliters of AE buffer. For the PCR assay, they used forward and reverse primers. Denaturation occurred at 95 degrees Celsius for 15 minutes, followed by 45 cycles, starting at 95 degrees for 30 seconds. Temperature was lowered to 62 degrees Celsius for 30 seconds, and then at 72 degrees for 30 seconds. This was used for the primers to anneal to the sequence. After that, elongation occurred at 72 degrees Celsius for 7 minutes. Magnesium chloride was used, deoxynucleotide triphosphate, Taq DNA polymerase, and after the PCR was completed, gel electrophoresis was used on a 2% agarose gel with ethidium bromide to view the bands. The results of the study were that 70 patients were initially enrolled, but then 35 patients had to be dropped due to indeterminate diagnosis. 16 patients out of those 35 were positive for Q fever, and the rest, 19 patients, had other febrile diseases. Out of the 16 positive cases of Q fever, 14, which is an 88% of the group, were all males. This happened probably due to occupational exposure. Men are usually the ones who are in agriculture, and that's probably why we can see this difference. And this is statistically significant because it has a p-value of 0.3. For anything to be statistically significant, we need the value to be less than 0.05. So this characteristic of males was the only significant value we can see between the two groups. The authors of the study compared their PCR results to the immunofluorescence assay performed on the same patients. Samples for PCR were collected on average at 16 days after the onset of symptoms. PCR showed a sensitivity of 81%, a specificity of 90% for Q fever. It produced a positive predictive value of 87% and a negative predictive value at 85%. Multiple samples could be run together for PCR, and results were confirmed on the same day, whereas the IFA needed 10 to 14 days to produce any results. The agarose gel electrophoresis shown here on the right. Patients on the left side of the gel, 1 through 4, were positive for Q fever, as is shown by the bands shown here, whereas on the right side, it's patients with other febrile diseases, and they are negative for the band compared to the Q fever patients. To summarize, Coxiella burneri is an intracellular bacterium that causes the disease Q fever. The serologic detection of Q fever has a long turnaround time, and it requires an acute and a convalescent sample to be tested. The phase 2 antibodies, that are the acute stage of the disease, can appear 10 to 15 days after the onset of symptoms, which means that any treatment will be delayed. Using a PCR detection method allows for the rapid detection of Q fever disease, and it can easily distinguish Q fever from other febrile diseases, thus allowing the physicians to start proper treatment. This article by Bay et al. Is very relevant to our time and age. PCR methods are now becoming one of the most valuable techniques. PCR provides fast turnaround time, and it's highly specific and sensitive. As time passes, more bacteria and viral infections that are difficult to detect using serology will be diagnosed using molecular methods such as PCR. A future direction suggested by the authors themselves was to increase their sample size. They only enrolled 35 patients, which is a small sample size to be able to make any good conclusions for the PCR assay. They also suggested that next time they could test the Buffy code instead of the plasma, and this would help increase the sensitivity of their assay. The authors could also expand the study to include patients from other hospital departments and not only concentrate on the tertiary care clinic that the study took place. This would mean an even larger sample size, providing better results. Thank you for listening. This is a list of my references. I hope that my research has helped us all learn a few more things about this rare disease called Q fever. Thank you.